candidiasis or just plain vaginal candidiasis. And sometimes that's just where in the progression of the disease the infection has taken place. I'll do that. I mean, yeah, there are some cases that you do your exam and like, oh my gosh, it's just fulminant yeast infection versus those who are mild. And then there's a couple of subclasses when we talk about with recurrence or frequent, and you have to be cognizant of other conditions that this may actually be a sign of, and that is making sure you're not dealing with a patient who has poorly controlled diabetes, or this is presenting because they are diabetic, they just haven't been diagnosed yet. In addition to the possibility of, someone who's immunocompromised, have been on other medications, things along those lines. So one should look into that as well.
And so, when you think about your patients that you're treating then right now, how do you usually treat them?
More often than not, I try and be sensitive to my patients. Being a male obstetrician, there's only so much that I can personally relate to. And so I offer them up basically a number of different options. Years ago, and I think it came out probably 23 years ago, there's a pill called Diflucan, and that Pfizer produced, and that became very, very, very popular because as one of their taglines in their advertising was, this is the only candidiasis medication a woman can take out in public, because everything else a woman has to put inside the vagina. And so it became very popular to have an oral medication that was just a one-time pill. Well, fast forward 23 years later, I've seen cases where, the Diflucan treats the predominant yeast, and that is Candida albicans. But I've seen cases where we're starting to see some resistance, where the yeast, the Diflucan's not working as well. And so we're either treating it with higher doses of a fluconazole type of medication, or I will go, because of the other two strands of yeast that we see also, which Diflucan does not help with, I will use Terazole, and be it the 3 or 7. I'm just a little, putting a cream in the vagina when a woman already has an excessive discharge kind of seems like insult to injury because it's messy. But the Terazole 3 or 7, which just relates to the number of days of treatment, is going to provide them effective treatment for all of the 3 predominant yeast infections that we see. So I give them the options. Go ahead. Yeah.
Oh, okay. Keep going. You can keep going now. I'll ask you my follow-up.
Okay. Well, it's just I try and give them the options of what they want. I was going to go into, if it's someone who has recurrent yeast infections and they haven't responded, then I will typically, start doing some cultures and make sure we're even treating the right species of yeast, and or is there something else going on as well?
Okay. So I have 2 follow-up questions to what you said. Is how much resistance do you think is out there right now in VVC? And to fluconazole?
I'm probably seeing about maybe 1 in 5 patients, 20%, coming in that a single Diflucan is not working.
Okay.
And so the option of treating them with a second dose, and I've seen a lot of my colleagues, myself included at times, will actually prescribe 2 Diflucans where you take one and then repeat in 7 days if symptoms haven't completely resolved, kind of prolonging the treatment. I've seen regimens published from experts around that, write articles about this stuff that say, 3 Diflucans kind of a little disappointed.
Okay.
And the
tell me
reason
why.
being just, primary endpoint, 52% clinical cure for product S versus 58% for fluconazole day 10. So you're not any better than what's already out there. And so for myself, right there,
Okay.
I'm potentially looking at a new product that is no better than what's already out there. And what's already out there is generic, very inexpensive, and it's once a day, one time, whereas this is twice a day for one time, one day. But here's the big kicker. This drug is going to be expensive. It's a new drug. The company's going to want to recoup their money, and I understand all of that. I'm very well been doing this long enough to understand the responsibilities of pharmaceutical companies. And so, but the problem is insurance companies aren't going to cover it. So it's not going to be prescribed, and it's going to be dead in the water because, A, it's not significantly better. In fact, according to this, it's worse at 10 days in terms of a primary endpoint of cure than what's already out there. So at that point in time, I have no reason to prescribe it at all.
Okay. So no, that's great information to know. So my next question is, what about the fact that I'm looking at day 25? Does that have any impact on you? Their endpoint there?
The problem with the endpoint results are better at day 25. The problem is, if my patient's not feeling better within a week, she's coming back in or calling. So day 25 is too long. If you recall, just not too long ago in our conversation, the ideal product, something orally that provides relief within 24 hours. And to wait over 3 weeks before this patient starts having significant improvement versus what's already out there, and you're only looking not even 3 out of 4 women at 72%, so to speak. Once again, this product is inferior to what I have available already. And it would have been put it on the shelf, stop wasting money studying it, because it's not going to go anywhere.
Okay, so my next question for you then is, so as you look at this, what about the MOA of this product? Do you have any reaction to that?
No. I mean, my feeling as a clinician, I don't care how its mechanism of action is, just as long as the end result is leading to a cure of my patient's symptoms and the yeast infection. So
okay, great.
It's very well, it's very well tolerated, and it's just and 63% eradication, but that's happening for both of them by day 10. So you're just not. This product is not wowing me. Other than it's another oral medication, but outside of that, not impressed.
All right. No, and like I said, be brutally honest with me because it's not my product. I just get info from the client to let them know. So,
sure.
So then my next question is, if you look at the dosing for this product, I don't know if you noticed in the profile, it said they're going to have an acute indication first and a recurrent indication if you looked at the dosing, and I want to know what your reaction to each is.
Well, when going to the acute, one tablet 12 hours apart, so you're having to take the medication twice in a day. It's once a day. It's basically a single day of dosing, which was great, and I was enthusiastic. As soon as I saw that, good, it's not a vaginal preparation. But the end results are lousy. The recurrent VVC patients, once a month for 6 months, I like it because now there's something from that standpoint. The dosing is fine. I mean, if I have someone who's gotten recurrent infections, meets the criteria, at least 3 of them, including the present